Let's take a look at the warm-up review. First question, anxiety is associated with altered levels of which neurotransmitters? So in anxiety there tends to be decreased GABA, increased norepinephrine, and decreased serotonin. Next, a patient's uvula deviates to the right when she says ah. So damage to what neurological areas would produce this abnormality? So rightward deviation of the uvula means that the muscles of the right palate are raising the palate, but the muscles of the left palate are not. So you can see rightward deviation of the uvula with damage to the left vagus nerve, or cranial nerve 10, and the left nucleus ambiguus. But then above the nucleus ambiguus, the right motor cortex controls the uvula by sending signals to the nucleus ambiguus via the right corticobulbar tract. But the nucleus ambiguus receives projections from both sides of the cortex, both left and right cortex. So a lesion above the nucleus ambiguus won't necessarily cause the uvula to deviate. The last one, what prenatal testing is abnormal in a fetus with a neural tube defect? So alpha-fetoprotein can be elevated in the maternal serum and also the amniotic fluid. Acetylcholinesterase can be elevated in the amniotic fluid, and then a sonogram may show the defect. All right, let's move on to the lecture.
Hello everyone and welcome to another Step 1 lecture. Students, I've been teaching in front of the camera for some time now, and though it's a little embarrassing, I do have a fan or two. Now many of them say to me, Dr. Lewis, you should really be an actor, get up on the big screen and become famous. But I tell them, I'm dedicated to teaching now. And anyway, I've been down that path before. Remember a little movie called, I don't know, Star Wars? Yeah, who do you think played Darth Vader? Yep. And oh, what was the name of that film, 2001, A Space Odyssey? You remember a certain supercomputer named Hal?
I'm sorry, Dave.
And then who could forget that groundbreaking comedy, The Cosby Show? Who was that who played the adorable but hilarious role of Rudy Huxtable?
Rudy!
I don't like to name names. So students, I appreciate all that feedback, but as you can see, I've already lived the life of a Hollywood superstar. Now, it's time to make you some superstars. Alright, so in our last lecture, we went over what happens when you stimulate the parasympathetic nervous system. We also talked about a few drugs that we use clinically. Now we need to focus on inhibiting the parasympathetic nervous system. And though it doesn't seem that complicated, students do get a bit tripped up here. We've said previously that the autonomic nervous system is a balance between sympathetic and parasympathetic. But inhibiting the parasympathetic nervous system is not the same thing as stimulating the sympathetic nervous system. There is a difference between the two. Now, in the last lecture, we filled out a table that listed the effects of stimulating the parasympathetic nervous system. Let's review that very quickly so we can predict what happens when we inhibit that stimulation. So remember in the lung, we saw that smooth muscle contraction, so that led to bronchospasm. In the GI tract, we had increased muscle motility and tone, so you got more digestion and transit through the intestines. Those salivary glands are going to make that copious watery secretion. In the heart, you're going to have a decreased heart rate, decreased contractility slightly. In the eye, you're going to get miosis, that's constriction of the pupil, contraction of the ciliary muscle, which leads to accommodation. In the lacrimal glands, you're going to see stimulation of tear production. In the bladder, you're going to see contraction of the wall and relaxation of the sphincter. In the penis, you're going to see erection, and in the clitoris, you see engorgement. So let's go ahead and look in the study guide here. What are the symptoms of inhibiting the parasympathetic activity? Now also, instead of saying parasympathetic inhibition, a question might ask you about anticholinergic or antimuscarinic effects. And that's going to make sense because as we went over in the last lecture, the parasympathetic nervous system uses acetylcholine as its major neurotransmitter and muscarinic receptors. Those are going to be located on the effector organs. So if we're blocking the effects of acetylcholine, then we refer to this as anticholinergic. If something is antimuscarinic, then it's not necessarily anticholinergic, it's simply blocking the muscarinic receptors and perhaps not affecting acetylcholine at all. However, when referring to the symptoms of inhibiting all three of these things, then the answer is going to be the same. Though technically not the same, antimuscarinic and anticholinergic are often used pretty interchangeably. Now, in the real world, we use the term anticholinergic effects a lot more often than we use antimuscarinic or parasympathetic inhibition. So what's the answer to this question? Well, recall that stimulating the parasympathetic nervous system caused everything to become very leaky. Remember old MacDonald, he started to drool because of all that organophosphate poisoning. Well, if we inhibit the parasympathetic nervous system, then we dry everything up. Now, many of you might be using the common memory tool hot as a hare, red as a beet, blind as a bat, dry as a bone, mad as a hatter, and bloated as a toad. Let's go through those together. So first we have hot as a hare. That's referring to the hyperpyrexia that can take place. Now because you're not sweating as much. Now this can be a little bit confusing because sweating is actually mostly controlled by the sympathetic nervous system, but the sweat glands are innervated with those muscarinic receptors. So that's why you see this occurring with anticholinergic activity. People will have the flushing, which will account for red as a beet. Next, we have blind as a bat. That's going to occur because blocking the parasympathetic activity will cause psychoplegia and mydriasis. Therefore, patients will lose the ability to accommodate. Patients will be dry as a bone because they won't be salivating as much. They're also going to be mad as a hatter. Acetylcholine is an important neurotransmitter in the brain as well as in the periphery. Therefore, you can see things like delirium when you inhibit it. Bloated as a toad is referring to constipation and urinary retention. And then another symptom that we see that maybe hasn't been used in the memory tool in the past is tacky as a polyester suit. And this is going to help you to remember tachycardia. So the vagus nerve, which is the major parasympathetic nerve in the body, helps to slow down the heart. Therefore, if you inhibit this, then you might get tachycardia. So let's move on to our muscarinic antagonists. So what drugs inhibit our parasympathetic activity? What are their uses? Now the prototypical muscarinic antagonist is atropine. So atropine will have many of the effects that we just described. Now clinically it's used to treat bradycardia. In the past it was also used to dilate the pupil. It's not used so much anymore because we have newer drugs that don't last as long. People generally don't want to be dilated all day. Now, we mentioned in our last lecture that atropine is still used to treat organophosphate poisoning. So what was that other medication that we used to treat organophosphate poisoning? Remember, it was pralidoxime. Pralidoxime acts to regenerate acetylcholinesterase, which will normally break down all the excess acetylcholine in the synaptic cleft. Now, atropine was also previously used for enuresis in children, but again, we have better drugs for that now. So atropine had a lot of uses in the past. Now let's talk about some other anti-muscarinic drugs, include things like homatropine, tropicamide, and cyclopentolate. So these are used topically to dilate the pupil. They have a much shorter duration than atropine, therefore they are used a lot more often nowadays. Next, we have benztropine. This is used to help treat Parkinson's disease and also to help reduce the side effects of antipsychotic medication. Glycopyrrolate. So this is used in anesthesia to help reduce salivary, tracheobronchial, and pharyngeal secretions. It can also be used to help decrease gastric acid production. Hyoscyamine and dicyclamine. So these are antispasmodics that are used for irritable bowel syndrome. So this will help with decreasing the painful cramping associated with IBS, irritable bowel. Scopolamine. Scopolamine is used in patch form that actually you put behind your ear, and its help is mainly with motion sickness. It's also helpful to decrease oral secretions, again, which can be used with patients who are mechanically ventilated over a long period of time. So especially with patients who can't clear their secretions very well, those that maybe have had strokes. Next, we have ipratropium and tiotropium. So these are actually inhaled drugs that can be used in asthma and COPD. They help decrease bronchoconstriction and can help open up the airways. Oxybutynin is used to decrease overactive bladder symptoms. And this brings us to another study guide question. What anticholinergics are used in the treatment of urge-type urinary incontinence? So it's not just oxybutynin, it's other ones. There's actually a nice mnemonic that you can use for urinary incontinence. It's off the darn toilet seat. So the O is oxybutynin, the T is tolterodine, the D is for darafenicin, the T is for atrospium, and the S is for seat is going to be for solifenacin. All right, so since pharmacology is such a tough part of step one, let's go over what we just learned in a Lewis Notes. Hello everyone and welcome to another Lewis Notes, and we're looking at our muscarinic antagonists. So we've got our list of drugs on the left. You might want to write those down. And then we've got their uses over here on the right. And this is just another exercise again to get this stuck in our brain. So the first one we have here is atropine. Atropine has a lot of uses, maybe not quite as practical as it used to be back in the past, but we still definitely use it for organophosphate poisoning. So let's grab that one and put that one over there. Next, we have benztropine. Benztropine can be used in the Parkinson's disease, and that can be used right there. And then it can also be used to treat some of the side effects with the antipsychotic drugs. Next, we have scopolamine. So scopolamine is used, especially if you're going to go on maybe a sea cruise or something. You're going to go fishing and you get seasickness or motion sickness, and you're going to use that there. Ipratropium bromide, used pretty often as a bronchodilator, especially in our COPD patients. You can use it in asthma as well. Oxybutynin. Oxybutynin is one of our drugs that we use for some overactive bladder. So if you have urge incontinence, then you can use oxybutynin for that one. Tropicamide, you're going to use this in your ophthalmologist's office to dilate that eye to be able to get that exam done right. Darafenicin is another one of those urge incontinent drugs that can be used overactive bladder, that type of stuff. Tiotropium, very similar to ipratropium, is a bronchodilator again. We can use that. It's a little bit longer acting than ipratropium. Next, we have the glycopyrrolate. Glycopyrrolate is going to be used to decrease airway secretion, so use an anesthesia more often to help decrease all the goo that's going to come out. All right, so just another review there for some of our muscarinic antagonists. All right, so let's move on. Moving on in the study guide, in what patient populations is atropine contraindicated? So several things here. Well, first we have patients with BPH, benign prostatic hyperplasia. These patients tend to have problems with urinary retention, so we don't want to make that worse by giving them atropine. Because antimuscarinics can cause hyperpyrexia, you wouldn't want to use this in a patient with hyperthermia. A big one that you might be tested on is that you never want to give atropine to a patient with acute angle glaucoma. Recall that atropine and all this anti-parasympathetic activity can cause cycloplegia and mydriasis, and this can actually result in an increase in intraocular pressure. You also need to be careful when using atropine in the elderly. Atropine can cause delirium. In fact, even less potent medications that we'll talk about in a little bit that have anticholinergic effects like antihistamines even can lead to things like delirium in the elderly. And finally, you want to avoid using atropine in patients with GI obstruction or ileus because again, that can make it worse. All right, so now let's move on to some other drugs that still have some anticholinergic side effects. We don't necessarily call them anticholinergics, but they still have that effect. So those are, again, the major contraindications, as we said before, of atropine. But let's look again in the study guide. What medications have anticholinergic side effects? The first generation H1 blockers are the first one I want you to think about. Diphenhydramine, doxylamine, and chlorpheniramine. So commonly used stuff that's even over the counter. Neuroleptics, especially thiaridazine, chlorpromazine, clozapine, olanzapine. And then also thinking about the tricyclic antidepressants. And then finally, amantadine. We don't use that quite as much as we used to, but that can also have some major anticholinergic, antimuscarinic effects. Now, test makers love to make questions where an elderly patient presents in acute delirium, and you need to be on the lookout for drugs with anticholinergic effects. Now, an example would be an elderly patient maybe just started taking diphenhydramine for some allergy symptoms and then started acting kind of goofy. All right, guys, that brings us to the end of our lecture part. Now it's time for the end of session quiz. I want you to pause that video, try to answer those questions on your own, and then we'll go through them together. First question here, identify the following drugs as direct muscarinic agonists, anticholinesterases, muscarinic antagonists, or a cholinesterase regenerator. So knowing these different drugs is incredibly important for your step 1 or level 1 exam. Some of these that we're going to go through were covered in the last lecture, so this is a big one. First one is physostigmine. This is going to be an anticholinesterase. Pilocarpine, that's going to be a direct muscarinic agonist. Next, we have oxybutynin. That's going to be a muscarinic antagonist, and we use that in urge incontinence. Next, we have atropine. That's going to be a muscarinic antagonist. Donepezil, that's going to be an anticholinesterase. Pralidoxime, that's the one unique one. That's our cholinesterase regenerator. Remember, we use that one for organophosphate poisoning. Bethanechol, that's going to be a muscarinic agonist. Neostigmine is an anticholinesterase. Darafenicin is a muscarinic antagonist. Ipratropium is a muscarinic antagonist. Tropicamide is a muscarinic antagonist. And benztropine, that's going to be another muscarinic antagonist. Scopolamine, same thing, muscarinic antagonist. Edrophonium, finally, we have an anticholinesterase. Tolterodine, that's going to be a muscarinic antagonist. That's going to be used for urge incontinence. Trospium is a muscarinic antagonist, again, urge incontinence. Rivastigmine is an anticholinesterase. We use that one for Alzheimer's disease. Homatropine, that's going to be a muscarinic antagonist, very similar to atropine. Pyridostigmine is an anticholinesterase. And then carbachol is a muscarinic agonist. All right, last question here. Which of the muscarinic antagonists discussed could be used to improve FEV1 in a patient with COPD? So remember, ipratropium and tiotropium. All right, guys, that's it for the video. I hope you learned something. I'll see you next time.